All right, so let's do another section. New section. Let's clear our minds.
Cool.
Let's do the complications of MI.
Okay.
One of the big ones that comes up in exams a lot is if you've got a patient with an MI
Yeah.
and a new murmur
Yeah.
and CHF,
3 of them.
they've blown a valve or a papillary muscle or something like that, and that equals surgery.
Yeah.
There's lots of MI complications. There's arrhythmic complications. There's pump failure complications. There's structural things like blown valves.
Yeah.
Where the MI is, which artery is involved can help you predict complications, and we talked about some of those on those animations.
We did.
And you can also think about MI complications as early and late. The single most important early complication of myocardial infarction is arrhythmic. In fact, in the 1960s, MI mortality went from 30% overall to 15% overall by doing one thing, which was
I don't know.
treating arrhythmias early. So early defibrillation, coronary care units, and they halved mortality just by treating these arrhythmias.
Interesting. They didn't do that before? What were they doing?
They just let
They're
people
like, hey, it
die.
looks like you're in trouble, buddy.
Defibrillation before the 60s really didn't exist except
Interesting.
in hospitals under certain circumstances. So
Cool.
overnight halving.
Love it.
What they used to do for MIs is basically put you in bed, give you some morphine, and see what happened. It was the 50s. They were good times.
That's what I did last night. Put myself in bed, gave myself some morphine, and saw what happened.
Yeah. So these arrhythmias early, fast or slow. After 48 hours, your arrhythmias really go down very quick. You can get shocked because of loss of heart muscle, because of stunning, valve dysfunction. Later complications, thromboembolism. You get a big scar, you develop a clot, it flicks off and goes down and takes out your gut or your legs or your brain. Myocardial rupture tends to occur about 48 hours later. Valve ruptures tend to be around, they can occur early, but 24 to 48 hours out later. CHF can occur immediately, of course, or it can occur down the line. And then Dressler syndrome is the one they really like in exam. Dressler syndrome is this sort of autoimmune pericarditis. Classically, 2 to 6 weeks after a big MI, they represent with chest pain that's pleuritic in nature. So Dressler syndrome, autoimmune pericarditis post-MI is a late complication.
Good one.
Another way they often talk about complications in MI is there's some good prognosis things and some bad prognosis things, particularly when you're talking about arrhythmias. So the good prognosis ones is if you've got a bradycardia that's narrow complex, that tends to be good prognosis because it means that the AV node isn't too sick. Whereas if it's wide complex or the AV node is involved, if it's wide complex, it suggests that the blocks are further down below the AV node, that the septum's involved. And if the septum's involved, that's bad. So Wenckebach, Morbitz type 1. PVCs are no big deal. Non-sustained VTAC actually is not a big deal if it's just for a few seconds, not a big deal. The bad ones is Morbitz type 2, where you have wide complex bradycardias or third degree AV block that's wide complex. CHF is obviously a bad prognosis. Persistent tachycardia. So 48 hours after your MI, you're still taking away at 110, suggests you've taken out a lot of myocardium. If you've got a new left bundle branch block, very bad. In fact, new left bundle branch block we'll talk about is probably still on the exams an indication for thrombolytics. Big infarct error obviously is bad. Failure to reperfuse. So you're having an MI, Aaron.
Yeah, I am. Okay.
I give you thrombolytics.
Yes.
And you've still got chest pain and you've still got ST segment elevation and it's not working. That's not a good sign.
I've failed my reperfusion.
You have failed me yet again. Let's go over this again. I know this is kind of boring, but I really like this in exam. Let's talk about the complications by location. So if you've got an inferior MI, 2-3 ABF, then the classic complications are blocks. These tend to be narrow complex blocks. You also can get hypotension and you give them fluid and it tends to be good prognosis.
Yeah.
Not much myocardium involved.
Right.
Anterior or anterior septal, bad. Because this is your left ventricle, you get CHF, you get shock, you can rupture your myocardium, you get bad bradyarrhythmias because you're taking out the septum and the conduction pathway. So anterior, bad, shock, bad bradyarrhythmias. Right ventricular infarcts, classically, this is an inferior with right ventricular extension. The complication you get here is hypotension. The hypotension here is treated with fluids. Just fill up the tank because even if that right ventricle isn't contracting almost at all, if you fill up the tank, it'll passively fill the left side. And these are classically associated with inferior MIs. Posterior infarct is also bad. It's a fair amount of contractile myocardium in posterior MI. So the biggest problem with posterior MI is that we miss it. Is that ST segment depression that you see we think is just ischemia and we don't thrombolize them, we don't send them to the catheter, but it's actually their posterior infarct. So when do you think posterior? Well, it's because of the anatomy that right coronary most of the time is involved, sometimes the dominant circumplex. You think about it when you've got a right ventricular infarct or inferior infarct. But if you see ST segment depression anteriorly, Think posterior infarction. All right?
Got it.
So let's go over more of these complications. These come up on the exams all the time. So if you've got an inferior MI, ST segment elevation 2-3 AVF, you classically get bradycardia, we talked about it. And the most classic bradycardia is Wenckebach. So that's the progressive prolongation of the PR interval. You can also just get sinus bradycardia because you have a lot of vagal tone. You can get papillary muscle rupture because that right coronary can supply the papillary muscle. So you can get the CHF, new murmur, shock, need a surgeon syndrome. Most of the time, these bradycardias in inferior MIs don't actually need therapy because what's happening here is that you're affecting the AV node and they're usually transient or it's associated with high vagal tone and they go away. So in terms of nodal blood supply, you need to remember that the AV node mostly comes from right coronaries, sometimes from the circumflex, and the sinus node is mostly coming from, the blood supply is coming from the right coronary artery, but also a lot of the time from the circumflex. So you can have a lateral infarct and take out your sinus node. You can have an inferior infarct and take out your sinus node. But in general, right coronary artery equals inferior, equals bradycardias, equals pretty good prognosis most of the time. You don't have to do too much. Even third-degree AV blocks, if you're having an inferior MI and you find a third-degree AV block, it's often a narrow complex third degree. That means that you're taking out the AV node, but the rest of the conduction pathway is okay. Even in that circumstance, that is a pretty good prognosis. Often it'll reverse by itself, or you do temporary pacemaking and they get function back later on.
All right.
So third-degree AV blocks, wide complex, bad. Narrow complex, not as bad. So here's another example question. Let's try and bring this together. Ready for your question, Aaron?
I'm ready for my question.
52-year-old presents
Yeah.
with chest pain,
Yeah.
stable vitals,
Yeah.
and the following EKG. Can you see this EKG? Let's go
I
over
can
it.
see that EKG.
And they're asking you, should you give the atropine to this person, epinephrine? Before you even look at the answers, you should have sort of come up with the diagnosis and what you do for this person, and don't get confused. These answers can confuse you.
Yes.
So if we look at this, we see
What do you got there?
ST segment elevation inferior leads.
Yep.
All right. So this is an inferior MI.
Yep.
And then you'll notice some arrhythmia here.
Yes.
So as soon as you see inferior MI, you already know, okay, they're going to start asking me about bradycardias and how I'm going to treat them. So here you have a P QRS, a P with a longer PR interval than a QRS, a P with an even longer PR interval, or even longer, and then it's dropped. So this is
Wenckebach.
Wenckebach. And the treatment for Wenckebach in an inferior MI is to do very little. So you sit there, you watch it. Yes, these can get worse. Yes, they can become more bradycardic. Yes, you would put on a transcutaneous pacemaker, but what they want to get at it in the exam is most of the time this is transient. It's not hemodynamically destabilizing. Fill up the tank, watch them. Usually they'll get better. All right?
All right.
Let's do right ventricular MI and its complications. So this is the inferior MI's evil twin. Inferior MIs, pure inferior MIs, have a very good prognosis. The mortality is very low, 1 or 2%. Not bad. It's not good if it's you, it's the 1 or 2%, but 98% of people do pretty well. So right ventricular infarcts are an extension, so it's more myocardium involved. They're much more likely to be hypotensive because they're taking out that contractile portion. The treatment of the hypotension in inferior MIs is fill up the tank. When do you think about it? You think about it when you have somebody with an inferior MI and you do right ventricular lead. So the simplest way is go inferior MI. Let me just do right ventricular leads, make sure there's no right ventricular extension. There are these tricky EKG things that you'll see in Alma Martu's EKG section, which is if you've got ST segment elevation in lead 3, which is much higher than lead 2, then you think right ventricular because lead 3 looks more at the right side of the heart. So if lead 3 is huge ST segment elevation, lead 2 has less ST segment elevation, you think there might be right ventricular extension. In the same way, if in lead V1 you have huge ST segment elevation and not so much in lead V2, or even ST segment depression in lead 2, same thing, because lead 1, V1 is right over the right side. So if you see ST segment elevation there, but not over this side, it suggests right ventricular infarction. All right, so big in lead 3 or big in V1, right ventricular. And in, as I say, ST segment depression in lead 2.
I have a question about that.
Go.
You're saying big in lead V1, right ventricular, but also big in lead V1. Oh, you're talking ST depression
In
V1.
V2.
Gotcha. Never mind.
In V2, ST segment depression suggests right ventricular infarction. V1, ST segment elevation,
Yes.
infarction. Lead 3, right-sided lead, more than lead 2, right ventricular infarction. I don't know if that'll be on the exam, More likely they'll have an inferior infarct patient who comes in really hypotensive. They don't have any bradycardias, and they'll say, what's the therapy? And the therapy is give them lots of fluids.
Yep.
So the treatment is fluid load. You can passively fill it, and beware of nitroglycerin. One of the tricks they'll say is they've got a right ventricular infarction, and what therapy should you give? And one of the options will be nitroglycerin. You give nitroglycerin, they vasodilate, they drop their preload, they dump their pressure. All right?
Bad things happen.
Bad. So here's another question. You ready? Ready for your questions?
Yeah,
I love
yeah.
questions.
I
How
love
you doing there,
questions.
people? You
Yes.
doing good?
Give it.
56-year-old, diabetic female,
Diabetes.
chest pain, really hypotensive, this EKG, what would be your therapy? So let's look at this EKG because it shows some of those classic things we just talked about. Nobody's going to miss, not even Tom is going to
Tom
miss
would
that
not
this is an inferior MI. This is
I
huge.
might miss it. I'll be honest.
Well, you
with
might miss it.
Yeah.
I might.
Huge inferior MI. The smart people amongst you will go, oh, now let's see if some of these right ventricular things are. Now, when I see this, I'm not smart. I just go right ventricular leads.
Yeah.
But you can see here that ST segment elevation in lead 3 is
Little bit
higher
bigger.
than lead 2.
Yeah.
More right ventricular. If you go over to V1, there's ST segment elevation.
Ooh.
But in lead 2, V2,
Some depression.
depression. So this is saying, I'm on the right side. There's something bad happening.
Great EKG. Great EKG.
And over here, so this is an absolutely classic example of a right ventricular infarct. The treatment of hypotension when you have a right ventricular infarct, is it epinephrine?
No.
No. Is it fluids?
Yes.
Yes. Is it nitroglycerin?
Absolutely not.
No. Drop their preload. They get worse. More presses?
Nope.
No, we don't like presses in infarcts. It just makes things worse most
Pressers.
times. So, bam, you've got to give fluid. So inferior MI shows right ventricular extension, fluid loading. How are we doing? We having good times?
I
That's
love that
good
one.
stuff
That was a
right
good
there.
one.
Is that good learning?
This
that
is
learning?
good
I'm gonna
learning.
I'm gonna go be a cardiologist. I'm out of here.
Yeah. How's our Steadicam? Is the Steadicam up?
Yeah, we're up.
Let's do a little Steadicamming. Let's just, just chat.
Just break it
pilot.
up a
Look,
little.
Just bring it in.
Yeah, bring it.
I want to talk
Yeah.
to you for a second.
Yeah. Shh. Shh.
You're
I got it.
muted when you do that.
Come over here.
So
Come
you
over
know.
here.
Thanks.
Don't freak out. It's going to be. We're going to get through this. All right. If you just focus, if you stick with me and Aaron, we're going to get through this. Okay. Love you long, Tom. Ready? Let's keep going because this is good. Is this good?
This is not good. This is great. This is
Let's
great.
do anteroseptal MI complications. So remember, V1 through V5-ish, V2 through V5-ish, you're taking out your anterior wall, you're taking out your septum. This is the big contractile part of the heart. You know, even Tom and Paul know that if I kill your heart, is that good or bad?
Bad.
That's bad.
I'm gonna need that one.
Yeah, it's bad. You're going to need your heart. So you get CHF and shock because this is the big pumping chamber. You're going to get bradycardias, or if you get bradycardias, this is a bad prognostic sign because this usually means that you've infarcted the septum where all of that conduction system goes, and it's usually wide complex bradycardia, and that means I've taken out my left ventricle and my septum, and now I'm getting bradycardic, and that is a very poor prognostic sign. So anterior MI, bradycardias that are wide complex, you are in serious, serious trouble. You can also rupture your myocardium. You can also rupture your septum. So lots of bad things can occur from big anteroseptal MIs. Let's now talk about sort of structural badness overall. So if you have a big MI, you can have a number of structural things that can go wrong. So you don't contract very well. Yeah, I get it. You have bradycardias from conduction abnormalities. But what we want to get at here is that you can actually rupture your myocardium. That MI can go all the way through the muscle wall, and the blood can leak out. And if the blood is on the outside of the heart, Tom, is that good or bad?
That's pretty bad.
That's bad.
That's bad.
So myocardial rupture, you would think if you have myocardial rupture, your heart's exploded, you're dead. But what happens here is you get this dead heart and it starts to leak a little bit and you actually get tamponade. So early on you might survive. You get a little bit of tamponade, you're dropping your pressure, somebody smart makes a diagnosis, they fill you with fluid to try and overcome the tamponade and they run, don't walk, run to the operating room and try and sew this up. You might save them that way. You can also get septal wall ruptures, mostly a septal MI. That rupture, you get an acute ventricular septal defect. So now the blood is swishing. Instead of going up through the aorta, it's going into your right ventricle. They have sudden onset of hypotension and badness. You treat these people with unloading them. You reduce their afterload so that you can try and get most of the blood to squish down the aorta. And then you call the surgeon, please drive fast German car quickly to hospital to save person's life.
All right, I'll come, I guess.
papillary muscle rupture or dysfunction, same kind of thing. This is classically with inferior MIs, and your valve stops working, and so you get shock and you get a new murmur. For these people, treat the shock, unload them, try and get forward flow, call the surgeon, please, MI, new murmur, a shock, surgeon, hurry.
Do I have to talk like that or no?
You don't have to talk
Okay,
like that
good,
because that would be silly.
Yeah.
And you put an echo on these people and you can see where the problem is in lots of cases. All right?
Love it.
Here's a question. Ready
Bring
for
it.
a question?
Yep.
Yeah.
All right, let's do this one. 52-year-old chest pain, always 50s.
Yeah.
I
Why
don't
is
know why.
that? Because you made them up? Oh.
And this guy's having his MI and you're like treating him, yeah, it's all good times. And then the nurse comes in and says, doctor, the patient's dumping their blood pressure. And I did my cardiac exam before they dumped their pressure, and I did one after, and I hear this new huge murmur through their chest.
Yeah.
What should I do with this person?
Yeah.
So what they're trying to get at is that there's something bad's happened, they've blown a valve or they've got a VSD, and so how do you treat these people? In the end, surgery. Yes, you can give them fluids, and yes, you can treat their shock, but what they're getting at is that this is a surgical condition. Now, I want to say something about these questions. Can I tell you something?
Please tell me something.
I made these questions up.
What?
Yeah.
These aren't real?
These aren't real
This
ABIM
is
questions. These are
crazy.
to make educational points. So don't think that this is the quality of the questions you'll get on the ABIM
Not
exam.
that easy. Yeah.
It's really hard to write good questions. They have to be vetted and tested. These are not vetted nor tested.
Yes, they are not.
These are to make educational
They're
points.
herbited. They're written by an Australian.
They're written in Australian for Australians.
And kangaroos.
So now let's take a break. Let's stretch a bit. Let's maybe do some steady cam work. Let's see what Dan's doing. Dan, what are you doing? We're in the studio here. Dan's up in the front there. He's the COO, Chief Cocoon Officer or something.
Chief
so he's up
Cocoon
there,
Officer?
you know, running
There
the
he
show.
is. Hi, Dan.
How you doing, Dan? Doing good?
I think he's on the phone.
He's on the phone. Probably we shouldn't be disturbing him right now.
He's
So we're taking a little break.
important.
When we come back, when Paul comes back with the steady cam, we're going to get right into the general treatment of acute MI.